I wanted to thank everyone for the opportunity to talk about some of the work we've been doing here at the Stone Center, and wanted to talk about the Ureteric Stents, looking at some advancements that have been happening and some associated complications. As we're all aware, ureteric stents, they're a vital aspect to urology. Their main goal is to help prevent ureteral obstruction, to help preserve renal function and promote ureteric healing while preventing stricture formation. That's used widely in all aspects of urology, including Endro-Urology, cancer, reconstruction, transplant in patients with chronic obstruction or infections. Stents can be left in temporarily, or they can be chronically exchanged. Ureteric stents, they are associated with local inflammation and mucosal irritation, leading to intolerability and stent colic. Many of these symptoms do mimic urinary tract infections and can lead to unexpected healthcare utilization, visits, clinic calls, potential for antibiotic overexposure, and patient morbidity. So with stent placements,
Can I add something right there, Runhan? Sorry to interrupt you so early, but that's like a personal pet peeve of mine. So whenever I talk to patients, I try to tell them that the stent is going to be the worst part, that it's going to mimic symptoms of an infection. And there is a lot of antibiotic overuse from that because, I had burning, I had blood in the urine, and I had to pee quite frequently. So my doctor just gave me antibiotics. And then the worst part is when they come back and say, you gave me an infection because I was peeing all the time and it was burning. So I think knowledge imparted to the patient is really, really key here.
Yeah, definitely. I think that's a very important point. Some of the studies I highlight a bit later do show kind of the impact that can have on a urology kind of clinic. And a lot of it can be mitigated with good patient education and expectations of what to expect. So stent placement is not without consequence and extra health related events. So just a brief introduction on history, just to know kind of where the stents came from. It's named after Dr. Charles Stent, who was a dentist, surprisingly, in the 1850s. He initially developed this molding material made up of latex and tallow and talc to help take dental impressions. This material was later used during World War I and in surgery, and became known as the process of stenting. It wasn't until the 40s where Dr. Herdman kind of came up with the first usable stent that kind of resembles modern day stents. These were initially kind of straight ureteric catheters running from the ureter to outside the urethra. And a lot of issues with these initial straight catheters, they were very prone to displacement. Initial materials that these stents were made out of were silicone and polyurethane, and we'll talk about the advances in the different stent materials over the years. And it wasn't until the 70s where doctors Hepperlin and Finley kind of developed the double J stent to help reduce migration. And since then, the double J has kind of taken over the stent market and become kind of the standard of care that we use today. One of the main procedures in endourology that kind of we use stents for are for stone management and for ureteroscopy. This was an interesting kind of graph I found looking at the change in percentage of management of stone treatment and the different types of procedures across the world. And over the last 2 decades, we've seen a significant increase in the percent of treatment for stone disease with ureteroscopy. Ureteroscopy has increased from around 46% of surgeries in 2007 compared to around 60% increase in 2017. And it looks like the trend is increasing. The rates for PCNL has been relatively stable. And there's been a decrease in shockwave lithotripsy and open stone procedures. Here's just a quick review of the Canadian Urology Association guideline on the management of ureteric calculi. This was last updated in 2021. I just wanted to highlight a few aspects relating to kind of stone disease and stent use. Ureteroscopy is the mainstay surgical treatment with a high stone-free rate and low complications. It's considered first line for ureteric stones, small renal stones, patients with pregnancy, pediatrics, and comorbid patients. Routine stenting is unnecessary. However, if it is a complicated ureteroscopy, such as if there is a suspected ureteric injury, if there's a stricture, solitary kidney, large stone burden, or infection, a stent should be placed. there is consensus among the three guidelines between the AUA and the EAU that advise against stenting in uncomplicated cases. This has been associated with increased morbidity without improvement in stone-free rate. Despite the consensus among the three guidelines, studies done between national surveys of urologists do show a bit of a different trend in practice. So this study was looking at an anonymous online questionnaires done by Dr. Ghani, who recently came here to talk. And this was a survey sent to the Endro-Urology Society. This was done about 10 years ago, looking at different preferences in practice regarding ureteroscopy, questions about sheath use, different size of scopes and sheaths, laser preferences, scope sizes, stents. So this was responded to by over 400 surgeons from across the world, and more than 40% of these surgeons perform more than 100 ureteroscopies a year. Ureteric access sheath was used by over 58% of surgeons, regardless of the case. And sorry, this is just for renal stones. And 64% of urologists that responded say they always left a stent, regardless or not of if the case was uncomplicated. And 43% of their practices do have some way of keeping track of these ureteric stent patients to prevent loss to follow-up. Similarly, this was another survey sent to 570 community and academic urologists. This was given to members of the Society of Government Service Urologists in the United States. And for the respondents, over 70% of the procedures they said were routine. Ureteric access sheath use did not change stenting practices for the majority of these urologists. And similarly, 85% of them said they would normally leave a stent, with about kind of half and half leaving the stent in for about 2 to 4 days compared to 5 to 7 days. I just want to highlight kind of these two time frames that we'll touch a bit later, and how that relates potentially what's happening on physiologically and what we do later see with some stent symptoms compared with kind of around that 3-day range versus around the 1 week time period. And another thing we'll touch on a bit later is kind of the differences we do see in the different stent removal methods, either with cystoscopy or stent being left on a tether. And kind of the last survey I want to highlight, this was done by the Stone Center here. This was an updated survey done last year, sent to the Endro-Urology member as well. Given a lot of advancements in equipment and laser technologies. Once again, questions highlighting on general equipment use, different intraoperative ureteroscopic access, and postoperative care. Over 51% of these respondents were Endro-Urology fellowship trained. And for the management of an obstructing stone, 70% preferred a primary ureteroscopy, while 30% suggested stenting for subsequent ureteroscopy. 71% of urologists left a stent after uncomplicated ureteroscopy, on average with an indwell time of 8 days. This was compared to 21 days if they considered it a complicated ureteroscopy. 62% of these stents were removed cystoscopically, and then 46% were given antibiotics postoperatively, on average for about 5 days. One thing I do notice, kind of maybe a bit of a different trend than here, is that when stents are typically left for short duration, I find a lot of places, either in the States, they prefer cystoscopic removal rather than leaving stents on tethers. It's shown in a couple of the studies kind of later on, but I thought it's just interesting to point out. That may be due to some kind of variation kind of in different locations and how they practice. So from these guidelines and the surveys, we know that ureteroscopy is being done more commonly for stone disease, and stents are being left in quite a bit of patients. And I just want to look at the impact that this has on the patients and what complications that people with stents can run into. So the CUA guideline also suggests kind of pre-stenting for 7 to 14 days, although it's not really based on any human studies. A lot of it's based on expert opinions and results that we do have from animal models. This study was done by Dr. Lang here, looking at a porcine model, pig model. So these pigs were stented for 2 weeks unilaterally, and they were looking at changes at 48 hours, 72 hours, and 14 days. They performed RNA sequencing, proteomic, histological, and smooth muscle function analysis on the kidneys and ureters. And what they found is they saw massive ureteral dilation, aperistalsis, and moderate hydronephrosis develop as early as 48 hours. They saw upregulations in GLI1, clusterin alpha, and collagen 4A2. These are markers that you normally see in upregulation are activated in signs of obstruction and acute kidney injury pathways. And they found that these findings were persistent for 2 weeks and even after 1 week following removal of the stent, but then kind of gradually reduced at baseline. So they did see increase in inflammatory markers that you expect in acute kidney injury, but most of these changes are reversible after stent removal. Another porcine model done by this group here looked at the degree of dilation or when that happened by doing intravenous pyelograms in a pig model as well, looking at day 0, 5, 7, and 14 days. They found significant ureteral dilation up to around day 5. Afterwards, the degree of dilation plateaued afterwards. They found that the ureteral compliance was better in the stented ureter by kind of estimating the volume of contrast that could be accommodated in the ureters. They found that stented ureters were able to hold a lot more contrast. And interestingly, they found that the ureteral diameter on the contralateral unstented side also increased, suggesting that there may be some systemic response happening. So a lot of this, which we'll touch on a bit later, but stems to the fact that with stented patients, you expect kind of initial dilation, upregulation of all the inflammatory and pathways kind of starts within the first 48 hours and kind of increases around 5 days and kind of plateaus afterwards, which can relate to kind of some of the symptoms that patients may have earlier on. So now I kind of want to pivot looking at advances in stent developments that have happened since back in the 40s, since they were initially developed. A lot of these advancements look to target different aspects or complications that can happen with stents, such as with infection and impact on quality of life. So the ideal stent essentially tries to minimize all of these aspects, all the while being biocompatible, affordable, and widely available. So advances have been made with different stent materials. A lot of interest looking at the distal stent coil itself and different stent coatings. So stent materials, they're most commonly made up of plastic polymers. They're used because they are inert, they're cheap, and they're well tolerated by the patient. The initial stent design used polyethylene when Dr. Herdman designed it back in the 1940s. It has good tensile strength, it's flexible, biocompatible, and hydrophobic. However, it's not used anymore due to its incrustation rate and brittleness of working with the material. Silicone stents were initially used as well. It was found to have less incrustation and infection rates. It could also tolerate higher temperatures needed for sterilization. But it does have fairly low radial strength, so it was more difficult to place, and also there's some difficulty with bearing external compression when needed for malignant obstruction. But modern day silicone stents are developed with hydrophilic coatings and improved biocompatibility. But development to try to combine the characteristics of polyethylene and silicone has led to the development of polyurethane stents, which has kind of taken over, become the mainstay polymer used today. Many companies do have their own proprietary blend or polymer. It's been more popular kind of lately has been the development of metallic stents. Metallic stents have increased rigidity and improved radial strength compared with the plastic polymers. and such. They're better for malignant obstruction. Metal is more prone to corrosion and less inert. A lot of these stents were initially used vascular stents or vascular surgery stents that were used off-label. And initial metallic stents had issues with patency, stent migration, and tissue ingrowth. However, newer metallic stents do have outer polyester fiber coatings, which do help to prevent tissue ingrowth. On average, the metallic stents are a lot more expensive. I think the resonance stent is around $880 compared to around $100 for our traditional polymer stent. But balanced with the prolonged indwell time of up to 1 to 2 years, they're kind of quoted for. They may balance out in the long term without needing constant stent replacements. And then there are many different stent types themselves. There's the traditional double J stent. There are self-expandable, balloon expandable, thermal expandable, or combination of those covered with polymers as well. So the resonance stent is one of the metallic stents I've seen used here. It's the double J metallic stent, and it's a nickel, cobalt, chromium, molybdenum alloy, and it has a occluded lumen to assure patency, and it's kind of this spiral formation of this metallic material, and it helps the urine flow under high compression compared to other polymer stents. Another metallic material that we do see commonly used is nitinol, which is a titanium oxide and nickel alloy that does have better corrosion and resistance to stainless steel.
I was just going to say to Runhan that we have the resonance stent here. We do use them. They're a lot more expensive, and the deal that we kind of have to go through with the protocol for the hospital is that they had to have, and that's only from malignant ureteric obstruction, obviously, had to have failed having a polymeric stent put in.
Oh, okay.
The other ones we don't have. So the allium stent, the one with the polyurethane one, just the one just right above resonance, we don't have that one. That's kind of like you put it in and it kind of opens up just like a coronary stent would, and that leading part to the left is what you use to pull it out when you take it out. And that polyurethane is supposed to prevent tissue from kind of growing into it and kind of holding it there like chicken wire.
Yeah.
And then the memocath is the top left one with the funnel looking, and that's supposed to basically expand at body temperature. And then in order to get it out, what you do is you do your ureteroscopy and it's still cold water over it. And then it starts to cool down. They're very expensive, but actually not even approved in Canada, so we can't use them. Those are only for like really pinpoint ureteric strictures or like one area of malignant ureteric obstruction. And the one on the right is the applied medical one, which is essentially a polymeric stent, but has a metal reinforced coil in the middle of it. So it very much looks just like a regular stent, but if you try to crush it with the finger, even a book, it's virtually impossible.
Okay. Yeah. I've seen, I placed one resonance stent since being here as a lady with, I think, chronic ureteric obstructions from strictures. And some of these, they are definitely not challenging, but do have different methods of insertions because of the different ways they try to maintain their patency. The resonance stent you have to place through kind of a sheath because it doesn't have a lumen in the traditional sense.
Yeah. And I think once you've seen one, it's really not too bad. Yeah. The key thing is to make sure you put up a guide wire before you take it out in case you lose access. That's the most important part, I find.
Yeah. And despite their kind of frequent use in cardiology, there's been kind of limited success of drug-eluting metallic stents in urology. And then the last kind of group of materials that have been kind of looked at are the biodegradable stents. These have been made from, or tried to made from many different compounds, such as synthetic polymers, natural polymers, biodegradable metals, or combinations of these. The goal is to help eliminate the need for cystoscopic removal and retain stents while also decreasing associated infections and incrustations. And it can also better for patients that may be lost to follow-up. And as we'll see in a bit, may also help with some of the symptoms that patients have. So the first reported ones back in 2002, the initial one was made up of a polylactylide co-glycolide, or PLGA polymer. but it ran into issues with inadequate degradation and toxicity. A lot of the challenges with biodegradable stent is looking at the timing of reabsorption that makes clinical sense and being able to have predictable degradation every time to avoid obstruction. And you want it to degrade it predictably each and every time you do it. The Ureteric stent, initially, the first generation developed by 2008, and some of the work's done by Dr. Chu in the Stone Center here. It's a radio-opaque glycolic acid polyethylene glycol barium sulfate polymer. It's similar to a dissolvable suture, kind of tightly wound on itself into a stent shape. It contains a hydrophobic outer mesh coating that dissolves rapidly and an inner coil that dissolves later. Their initial first generation model began to degrade at 3 weeks and was completely degraded by 10 weeks. In their studies, it had similar drainage compared to biostable polymer stents. There was less ureteral dilation and fewer positive urine cultures and softer axial rigidity. Thanks to Dr. Chu here, we do have some pic images of the stent being placed. So you place it the same way. You're able to place it over a guide wire. And then here's the image on the left at kind of 2 weeks post-operatively. The stent's kind of still in situ, but you do kind of see a bit of uncurling of the distal coil in the bladder. At about 4 weeks, you see kind of degradation of the distal coil where the proximal coil in the kidney is still there. About 5 weeks, mainly just the proximal coil left, and at about 7 weeks, it's completely degraded. So this was their first generation model. Having the stent, this one degraded by 7 weeks, but generally all of the material degraded by 10 weeks. This may still be a bit long for those that may be kind of clinically relevant if you're thinking for after ureteroscopy, ideally being degraded after a couple of weeks would be more ideal. So this led to the development of their future generation of their stent. So this study looked at the third generation of the Ureteric stent. It had reinforced axial rigidity, and it was designed to degrade distally to proximally due to variable degrees of the degradable coating. This benefit is it does help with potential obstruction in that if you kind of maintain your proximal portion of your stent and you obtain the flow up there, you're less likely to run into issues with ureteric obstruction. And also by degrading the bladder coil first, you ideally have less bladder symptoms. And a lot of the hypothesis is that the distal coil itself can cause significantly irritative voiding symptoms. So in this study, they placed 10 Ureteric stents and 6 traditional polymer stents unilaterally in 16 pigs. The Polaris stents were removed after 2 weeks. Of the 10 Ureteric stents, 9 of them, or 90% of them, were completely degraded by 4 weeks. The remaining Ureteric stent had some small remaining bladder fragments left over that probably would have degraded in the next few days or so, but were all essentially clinically degraded. All the stents began to degrade by 14 days, and 40% of the stents were completely degraded by a bit over 2 weeks. Excretory urograms showed equivalent drainage and less hydronephrosis in the biodegradable stent. Blood and urine parameters were similar, but with no incidence of obstruction in any of the stents. There was a transient increase in serum creatinine, but that kind of resolved in a few days. And on histology analysis of the bladder and ureter, they didn't see any inflammatory reaction of the kidney or the ureter to these biodegradable stents. So this Ureteric stent is currently undergoing a phase 2 multi-center international trial right now. So here's a good summary photo I found of just the 3 kind of widely available groups of stent material. So you have the polymers, which is kind of our bread and butter that you use all the time. That has good biocompatibility. It's soft and malleable and well tolerated by patients. If you need a bit more radial strength, consider longer indwell time. There are the metallic stents for ureteric obstruction, for malignant obstruction. And then kind of up and coming are the biodegradable stents, which try to minimize many of the complications that we do see with the stents. Next, I just want to briefly touch on kind of the stent coil itself. There's been a lot of research, primarily a lot more interest more on the distal stent coil than the proximal one. The distal coil rubbing up against the bladder mucosa is believed to cause a lot of irritative voiding symptoms. And also the distal ureter does have the highest nerve density along the ureter. And studies have shown that the positioning of the distal coil within the bladder can have an effect on symptoms. When looking at the ureteric stent symptom score, they found if the coil itself crosses the midline into the contralateral part of the bladder, patients do have a lot worse body pain and urinary symptoms. Studies have also shown that try to minimize the size of the stent and does cause less symptoms as well. And there's been designs or studies looking at changing the shape or the amount of material of the distal coil using spiral shapes that are a bit more flexible to help conform better to the ureter. There's also been stent models with kind of one-way valves to help decrease the amount of reflux that can go up the stents as well. This stent is one of those, kind of a Polaris. It's called the Polaris loop stent. It has two unique bladder loops. Doesn't look like it, but they quote that it has 70% less material in the bladder. And a study by Yoshida and colleagues looked at 85 patients post-ureteroscopy, comparing this intraureteral stent versus the conventional stent, left in for 14 days. And they found improvement in pain, IPSS score, and analgesic use. We're looking at subgroup analysis. They found a significant improvements in bladder and groin pain, incomplete emptying sensation, and also daytime frequency domains. And they found no difference in stent complications. But I imagine these stents are a bit more difficult to remove, and it's a bit harder to leave these on tethers. And one other interesting kind of stent design I found, this called the J-fill stent, in that it has a proximal coil and a short segment of proximal ureteric stent, but the remainder of the distal ureter and bladder portion is a small 0.3 French suture that's left in the bladder. This was a prospective cohort study and compared this J-fill stent with the conventional double J pigtail stent left for 2 weeks. They did find improvements in their ureteric stent symptom questionnaire at 2 days and at 2 weeks. Patients did report lower urinary frequency, incomplete emptying sensation, and dysuria, and there was no reported dislodgement or worsening hydronephrosis. That's a picture I found on the website for the company, but I find if you're using, I would think if you're using for the obstructing stone, it'd be a bit more challenging to assure that the stent itself was actually bypassing the obstructing portion of the stone and not just the suture itself. And the studies I looked at it were just looking after post-ureteroscopy. And looking at stent removal, the two main methods that we use for stent removal is leaving it on a tether, but tethers can cause irritation by hanging out the meatus, and there is a risk of potential dislodgement. And then the other would be cystoscopic removal, but cystoscopic removal could be uncomfortable for patients. And there's also the extra healthcare utilization by needing a procedure room and needing kind of flexible cystoscopes. So there's been other ways to look at to take out stents. Some of them may be kind of more logistically sound than others. Some have tried using vascular access sheaths with a combination of fluoro, but then there's a radiation risk for that. Some have tried, or there have been stents developed with a magnetic kind of tip at the end, and then using a retrieval catheter to remove. I've seen these used in pediatrics, and the biodegradable stent would kind of circumvent all of this altogether.
Runhan, can I just interrupt you back? If you go back to that magnetic stent, I just want to point out the local inventor of this, who is Dr. William Taylor from Richmond. Just want to point that out to everyone. He and his colleague invented this essentially, and it's very, very strong magnets. And basically, it's a little catheter you can get anyone to put in. So you don't need a cystoscope. Usually, these were removed by a nurse. And when you put it into the body, you could actually hear it click. You just kind of twirl around because it looks like a coude catheter. and you just rotate it around in the bladder, and you can actually hear the magnets click, and then you pull it out, and it's incredibly strong. So this worked really well, and this got licensed by a few companies, by Cook, and then by a German company, Urotech. And I'm not sure where it's at now, because I think the patent is now up, because it costs quite a bit of money to keep that patent up. But I just want to point out it's a local invention.
Oh, that's interesting. Didn't know that. Yeah, I used it in residency. It was for a pediatric case because you don't want to scope them again, and it's not that, and it's a bit more difficult leaving a tether. But yeah, it does have that very satisfying click that you hear.
Click. So you heard it. So it went pretty well then.
Yeah, it went well. You do have to kind of, like you said, like swirl it around a bit until you kind of find it. But definitely more tolerable for kind of for children.
So Ben, we used to use it at Children's. We had it from Ureteric.
Interesting. Great.
And it is actually very good for children because it avoids a general anesthetic and use up a lot.
Yeah.
The problem is that the German company Uretech has stopped shipping them to Canada because of high fees that Health Canada asked from them. So we haven't had it for like 3-4 years now. But it was really a time saver for us. Now after every pyeloplasty, now we have to take the patient back in 4 weeks to do a 6 months old, and then scope them.
Was that direct from Urotech, or was it through Red Leaf Medical?
I believe it was direct through Urotech.
Okay. Because I know that Red Leaf Medical was going to distribute some of these. That's Charles Coe in Toronto, who's a really great person. Yeah. I would have a discussion with them because they're very innovative, and they can usually get things in and avoid some of these. And they may not be able to avoid it, but maybe they would avoid it if they were able to do that. So we can talk offline, but that's great to hear that you guys were using it.
Just one historical footnote here. If we go back 100 and something years in our profession, we called urethral sounds because when you put a curved metal instrument into the bladder to treat a bladder stone, you would move it around until you tap the stone and you could hear the sound of metal on stone. So we're back to where we started.
It's true. That's why they call them sounds, isn't it? Yeah. Clink, clink, clink.
Okay. Just moving on. I just want to touch briefly on stent coatings. There's been several different trials, stent coatings. Many of them are quite complicated. I don't want to dwell too much on them. But a lot of the different coatings attempt at reducing complications of some form or the other with ureteric stents. There have been ones tried to help inhibit incrustation by using inhibitors of stone formation, such as glycosaminoglycans. Many have attempted to limit bacterial infection by using drug-coated or antibiotic-coated stents. Others have looked at using anti-inflammatories to help reduce patient symptoms. But a lot of these may have shown some benefit in vitro or in bench studies, but have shown clinical and in vivo studies have the data's been a bit more lacking. So like I mentioned, here's just highlighting a few. They tried the polyethylene TPU stent with coatings to try to decrease stent incrustation. They looked at silver sulfadiazine stents towards bacterial colonization. There's been looked at cross-linked kind of polymer hydrogel networks to reduce bacterial adhesions. And also, I think some of the work done by Dr. Lang here at the Stone Center have been looking at antimicrobial peptides to try to prevent bacterial adhesion and biofilm and incrustation as well. But there's been a long list of different stent coatings that have been tried, but long-term outcomes in vivo studies still remain to be determined. So biofilms, kind of shifting over to biofilms and incrustation. Bacteria do release different polysaccharides, lipids, nucleic acids, and proteins that form a protective layer on the stent surface. The stent acts as a scaffold for bacteria to attach, and the bacteria that adhere to the surface do form these resistant matrices. Vetchart and colleagues did found that the biomass did kind of increase the longer stents were left indwelling in patients. And they found that the degree of biofilm, or the actual biofilm mass, was associated with hematuria, bacteria number, and worsening patient symptom scores. The difficulty with targeting these biofilms is that the urine culture, either pre-op or intraoperatively, is not representative of the overall stent colonization population. And they believe it is multifactorial, having to do with a combination of the stone, the patient, their comorbidities, their microbiome, and it is quite complex. And also in studying these biofilms, it's challenging with finding a standardized way to extract the biofilm on these stents. So once these biofilms form, they act as a scaffold and help retain urine crystals and acts as a nidus for stone formation. In addition, urease-positive bacteria do produce ammonia by breaking down urea into ammonia and CO2, which increases the urine pH, resulting in magnesium ammonium phosphate crystals to form. Some simulation models looking at how fluid flows around the stent have shown that areas of increased incrustation do occur at areas with decreased wall shear stress. These are highest around the inactive side holes of the stents. They were able to show that they increase the wall shear stress. They were able to decrease the incrustation, such as increasing the flow rate. But they've shown that with thinner wall thickness and triangular side holes from their flow models, they were able to decrease the amount of incrustation. Other studies have shown that the degree of surface charge on the surface of the stent and the hydrophobicity of these polymers can affect incrustation as well. But from clinical studies, a lot of retrospective clinical studies, the main risk factor for incrustation is the length of stent indwell time. And this becomes an issue because it can lead to device obstruction and failure, leading to infection and requiring intervention or further intervention for stent removal. So this is a retrospective review that was done quite a while ago, looking at kind of the natural history of these stents after ureteroscopy of around 300 patients. 11% of their stents were left indwelling for greater than 6 months. For stents left less than 6 weeks, around 10% of them were encrusted. From 6 to 12 weeks, around 48% were encrusted, and greater than 12 weeks, almost more than 3/4 of these stents were encrusted. But it is interesting to note only 6% of these stents required further intervention for removal. So the degree of incrustation itself, whether or not it's clinically relevant and making it a lot more difficult to remove, still remains to be seen. And associated incrustation rate, or infection rate, sorry, of around 7%, kind of in keeping with what we expect kind of normally. Similarly, when looking at stents that have been placed greater than 3 months, they found 30% of these stents had complete luminal blockage. However, the clinical obstruction rate in these patients was only around 4%. So the stents are still kind of being able to allow urine pass through, not directly through their lumen, but around the stent as well. And next, looking at kind of impact that stents can have on patients' quality of life. There's been a lot of study, a lot of research going on around this recently, and as well here at the Stone Center. We do know that urinary and stent symptoms can have a large impact on general health. We know that greater than 80% of patients will complain about some symptoms after stent placement. Dr. Lingemann and colleagues found that analgesic use peaked after the first day of stent placement, with pain worsening up to around 4 days. And predominantly of storage symptoms, incontinence, dysuria, and hematuria can significantly reduce quality of life. And I think this is what Dr. Chu mentioned, is just kind of patient education and kind of patient expectation. A lot of this can help reduce a lot of the anxiety and a lot of the subsequent events that happen after stent placement. I mentioned this a couple times, or it came up in a few studies earlier, but the Ureteric Stent Symptom Questionnaire was developed by Joshi and colleagues. And it was kind of helped narrow down to these 38 questions looking at 6 domains of health, about urinary symptoms, pain, general health, work performance, sexual matters, and additional problems. In particular, one aspect is looking at the impact on their daily activities. So this was done as kind of validation of their Ureteric Stent Symptom Questionnaire, looking at 85 patients who underwent unilateral ureteric stent insertion after ureteroscopy. 78% of these patients reported some bothersome symptom. 80%, and these stents were left for 4 weeks after the ureteroscopy. A bit long for today's standards, but gets the point across. 80% of these patients did have some pain affecting daily activities, with 26% saying they spent 2 days in bed, which I found quite surprising. 42% of patients said they had reduced activity by more than 3 half days. 58% of them said they had some reduced work capacity, with a third of patients saying they had sexual dysfunction or unable to engage with sexual intercourse while having these stents. And only 15% of patients did not experience any pain or discomfort during physical activity. And 70% of patients with stents report they did need to take some anesthesia over the duration that they had the stent in. So that we know that stents sometimes when you're leaving, what's the optimal duration to leave these stents in patients? And a lot of them have centered looking at short duration, kind of anywhere from 2 to 3 days, compared with longer from anywhere from 7 to 9 days. This is a retrospective review of 242 patients. This was done in Iowa, looking at patients with 3 versus 7 days. All these patients were given a standardized prescription for an alpha blocker, a few days of antibiotics and anticholinergics and narcotics as needed. This is where I found they tend to prefer looks like the cystoscopic extraction in the States, where all the patients in the study were given the option of having a stent on a tether. However, 48% of the patients actually refused the extraction string. But in their primary outcome for the study was looking at post-procedure related events, which is the PRE, which consisted of anything. So extra clinic phone calls, emergency room visits, or unplanned clinic visits. And what they found was that there were 1 in 3 patients had a post-procedure event within 30 days of their stent insertion. This was 39% of the 3-day stent group compared with 21% of the 7-day stent group. And when focusing just on the 3 days after stent removal, they found in the 3-day group, 23% had post-related events compared with only 3% of the 7-day group. And when looking at what exactly these post-related events were, they found that over half of these post-procedure related events were extra phone calls to the clinic itself. And the most common reason for these phone calls or complaints, not complaints, but complaints of pain, was for flank pain and hematuria. And they found a significant increase or trend of increasing flank pain complaints within the group that had their stent for 3 days compared with 7 days. They found no difference in infection rates, hospital admissions, or postoperative development hydronephrosis in either stent duration group. And as seen from the previous porcine model, you could probably hypothesize that when the stents are moved at around 3 days, that's kind of when a lot of your ureteral dilation, when a lot of the inflammatory pathways are kind of starting to act. And it's after around 5 days when all that settles down is when kind of some of the symptoms settles down, or that's what a lot of the hypothesis is around.
This was some of the most interesting data, Runhan, especially here, because everyone thinks that shorter is better. Just because that's intuitively what you would think. And I used to leave my stents in for 5 days, and all of my colleagues in our research consortium left it in for 48 hours. So I started going to 2 days, and I can't tell you how many phone calls I got, and maybe Joel and the others can pipe in as well too. But I just found it was just so bad when I left it in over 48 hours. And then if Dirk's online, I can comment. But whenever we stent pigs, and we've done certain time points, like particularly looking at things like the degradable stent, we had to look at inflammatory markers and pathology. And something happens around the 72-hour mark after pigs get stented. And obviously it's a bit more inflammatory, but you would assume the human would be similar. And it is the inflammatory reaction is massive before 72 hours. And then after 72 hours, things change. And Dirk can maybe comment on the peristalsis, because we know that it changes after that time. So I don't know if Dirk, if you want to comment.
Yeah, I can just briefly. So generally what we've found is that within 24 hours of placing the stent, the ureter dilates, overstretches the smooth muscle. which results in smooth muscle dysfunction and the loss of peristalsis, which also then, of course, significantly slows urine drainage and causes hydronephrosis. And then the inflammation increases significantly over 72 hours and then sort of stabilizes. And so I suspect that, at that 72 hours when it stabilizes, I don't know if the patient just kind of gets used to it, or if there's actually sort of a decrease in pain. And then the longer the stent stays in, you actually get remodeling of the tissue and development of fibrosis, and so on and so forth. So there is the potential for some longer lasting impacts, but whether or not they're clinically relevant, obviously that remains to be seen.
I think this is something that I always keep in mind, stuff that Dirk has told me, because he's actually shown that fibrosis actually starts forming. And we all think, oh, well, it's not a big deal to leave a stent in longer, particularly after things like a reconstructive pyeloplasty, where, you want some healing, but you don't want particular fibrosis, or, for instance, if you have a stricture that you've dilated. So this is something that I've kept in mind now. And there's, a lot of studies where you do an endopylotomy and put a stent in pigs and see, really, they only show that about 2 weeks is enough, and some of them even show 7 days is enough. So yeah. I think that we're probably leaving in stents a little bit too long.
Yeah. Thanks for the input there. I definitely think this kind of study will highlight that as well. This was done by Dr. Ghani as well, using the music registry in Michigan of over 4,000 unilateral ureteroscopies. And he looked at stents that were left on 5 days with a string versus stents that were left for 9 days without strings. And he actually broke it down by kind of date with stent removal. And then they found that the rate of emerge visits was significantly higher when the stent was removed before 4 to 5 days. Of course, here, all the stents that were left for 0 to 4 days, they were left on strings, and everything kind of 9 days and after were cystoscopically removed. But I'll show you some data after that that may not matter a whole lot after with regards to pain symptoms. So there's currently a multi-institutional prospective study underway at UBC here being one of the sites, looking at adults undergoing unilateral ureteroscopy, uncomplicated ureteroscopy. It's currently enrolling, looking at 3 to 5 day stent insertion versus 7 to 9 day duration. And here's an abstract we recently submitted here at the Stone Center. This was using prospectively collected real-world clinical data from a Boston Scientific stent registry that was initially made for European Union regulations. So it consisted of 271 single ureter stents placed for stone management. And it looked at the PROMIS pain interference and pain intensity scores, which is similar to the Ureteric Stent Symptom Questionnaire. Looked at prior to day of intervention stent removal and 1 month post stent removal. Patients were grouped by short duration, 0 to 6 days, medium 7 to 10 days, long duration 11 to 29, and very long over 30 days of indwell time. What we found was that there was no significant difference in pain scores among the different duration groups. On sub-analysis within the long duration group, 11 to 29 days, patients did have less pain the closer they were to the 11-day mark. When looking at height stratified by the length of stent, we did not found any effect, and we found no difference in pain symptom scores based upon the method of stent removal. And then men reported lower pain scores than women, which does contrast some of the previous studies in the literature. So this stent registry was developed to look at their TRIA stent. It is a newer stent by Boston Scientific that you guys have been using here for a bit of time as well, but was new to me when I came here. So this is a unique tri-layer design stent. It contains a non-ionic, smooth, hydrophobic inner and outer PercuShield coating on their PercuFlex stent. So their PercuFlex is a proprietary polymer, polyurethane polymer that they used. It has the PercuShield itself has less electrostatic forces, which resist calcium and magnesium deposits on the surface of the stent, and that's believed to help with incrustation. I'll show some of the bench studies that Boston Scientific performed, And I found interesting, it does soften by about 40% at body temperature to help with patient tolerability while being softer, firmer for stent placement. And it is compatible. It is rated up to indwell times of a year and is available in soft and firm durometers. So this was some of the bench studies that was performed by a third party for Boston Scientific, available on their kind of product monograph on the website. And then they looked at salt deposition in both sterile urine cultures and also cultures with spiked with protease, so a urease positive bacteria. And they found there was kind of around, in the sterile urine, there's around 40 to 60% less salt deposition compared with competitor stents. And in the bacteria-infested urine, there was around kind of 20 to 40% less salt deposition. Whether or not this relates to clinical incrustation and infection still remains to be seen. And this other study that they did looking at the durometer of the stent, how that changes at around room temperature from 25 degrees to around 37 degrees. The durometer itself, it's a standard way to measure kind of stiffness or hardness of the materials. It's more of a relative comparison. But they found that after the stent accustoms to body temperature, it does soften by around 40% to help with patient tolerability. And finally, our last abstract I wanted to touch on is looking at this Boston Scientific Registry as well. It was it compared kind of TRIA stents to other commonly used Boston Scientific stents. It consisted of over 300 patients who had at least one ureteric stent insertion. Patients filled out PROMIS questionnaires looking at pain, interference, and pain intensity. The primary endpoint of the registry for European regulations was technical success, but secondary endpoints, we looked at these pain scores, incrustation, and infection rates. Just for the sake of time, won't go too much in on the actual PROMIS questions, but they're very similar to the ureteric stent symptom questionnaire, looking at the pain itself and impact on your activity and quality of life. So what this registry showed, baseline characteristics, the TRIA group, the stents were left in for around 11 days compared to around 9 days with the non-TRIA group. Average stent length was comparable at around 25 centimeters. Stent removal method, the TRIA group was around 42% on a tether, while 55% in the non-TRIA group had it on tether, so it was a bit different. Looking at the prescription patients received, the TRIA group did have a bit more antibiotics and a bit less pain medications prescribed, but I will chat a bit about that in the analysis. But the primary endpoint of technical success was equivalent 98% in both groups. Pain intensity and pain interference scores for the TRIA group was significantly lower at the time of stent removal. Literature has shown that with the PROMIS score, there's a minimal important clinical difference of around 2 to 3 points, which this did reach. TRIA did have lower pain scores at the time of stent removal compared to baseline, compared with the non-TRIA group. And because the non-TRIA group did have higher pain baseline, they did have a greater decrease in their scores after removal. Sorry, David, you're just on speaker.
Yeah. Is that, I think you're finishing up, right, Runhan? Sorry,
yeah, I'm just finishing up
because we've been adding so many comments.
I just have like one more slide left.
Yeah. Perfect.
And then finally, on multivariate analysis, it showed that once again, there's no pain difference based upon removal method, and there's no difference based upon their antibiotic or pain analgesia prescriptions as well. And we saw no differences between the two groups in infection and incrustation, likely due to the short indwell times. So in conclusion, ureteric stents have been widely available and used for decades, and their use seems to be increasing. We touched on some of the associated complications and a lot of the advancements that have been happening over the past few years and some of the research that's been ongoing here at the Stone Center. I'd like to thank everyone for joining in this morning, and thanks Dr. Chu for the mentorship for this, and I'd like to thank everyone for the interaction as well.